Welcome to the Connecting Health Professionals with People podcast brought to you by Pronex Inc. I'm Aran Kabakov, and with me today is Dr. Josh Roller. Dr. Roller, welcome. Dr. Roller, you've performed over 11,000 weight loss procedures. What initially inspired you to get into bariatrics to begin with? And also, how has your perspective changed?
It started when I was resident at UT Southwestern, just doing my general surgery in Dallas, Texas. And one of my mentors, named Dr. Provost, I liked the type of surgeries that he was doing. And in residency, you go through all different types of surgery. You learn everything in the abdomen. So I started doing some research with him while I was doing my training, and then I decided to go do the fellowship at Duke University in weight loss surgery. But really, just because I firmly believe in minimally invasive surgery. When you're a junior resident, you take care of all the patients. You don't get to do any of the surgeries, take care of all the patients. And it was clear to me that the patients with the tiny incisions were going home the next day and the following day versus a week in the hospital. And they were happier. The residents were taking care of them. Everybody was happier. Everybody liked that versus the big, huge open incisions. And so doing a weight loss surgery at the time was kind of the preeminent minimally invasive surgery you could do. I got to Duke. Fortunately, got into that fellowship. It was a great year, and within a month of just being in the clinic and doing the surgeries, but really being in the clinic with the bariatric surgery patients, I just realized how much happier they were. Like what an impact you can have on somebody's life when they lose 100, 200, 300, 400 pounds, and they're happy to come in and see you. And so I really felt like I was developing relationships with my patients that were beyond just get my gallbladder out and I'll see you again, never. So really was just developing that kind of relationship with patients. And I loved it. I love that they were happy. I love they're coming off their medicines. I love that they felt better. And then, I love the fact that they actually like coming to see the doctor. Because generally speaking, as surgeons, everybody's like, oh my God, I got to go to the surgeon's office. It's, you equate surgery and, pain and discomfort. That's not how it is in weight loss surgery.
And to that point, there's so many options of weight loss, right? As you see ads for everything, and then there's also
Yep.
the new pharma options. So
Right.
when should someone consider bariatric surgery as a solution, and how do you guide them through that decision?
So generally speaking, we would consider our practice anybody with a BMI of 30 and higher. Insurance would say 35 and higher. What that means is probably 60, 70 pounds or more overweight. The body mass index or BMI, you just Google it, get on a calculator, type in your height and weight. But, that's when I think you should start considering it. I think, and it's been proven, it's the only successful long-term solution to obesity. I think medicines have are fine in the right patient population, meaning 20, 30, 40 pounds, maybe most. But what you have to realize with medicines and what we've known for decades, and it doesn't matter what the medicine is, whether it's the new GLP-1 injectables or the old phentermine, once you stop the medicine, the weight comes back. And I find that our patients want to get off medicines. They don't want to be dependent on drugs to be healthy anymore. So surgery, it kind of changes the wiring on the inside, which helps change the wiring up here. Feel full faster. You don't absorb all the calories that you're eating, and you're done. You just start to get off your medicines. Your high blood pressure goes away. Your sleep apnea, diabetes, your joint pain, back pain, reflux, your cancer risks, all of it start to go down. And so then you look at just the effectiveness of surgery versus medicines. And what I would say, I love to do the duodenal switch procedure. It's our bread and butter, great surgery. So let's compare it to the best GLP-1. The best GLP-1, you'll lose about 20% of your weight. So let's say you're 400 pounds. That would be 80 pounds at a year. Okay, so now you're 320. Well, that's good. That's better than 400, but that's still not good. That's not good at all. And so now you're on this injectable that you have to be on every month for the rest of your life to maintain the 80-pound weight loss. So if that costs you $1,000 a month, $12,000 a year for 30 years, you're hundreds of thousands of dollars into it versus a surgery that now most insurance companies are covering because they see the positive effects that it has on decreasing healthcare costs. The average diabetic costs $13,500 a year. We have an 85 to 95% cure rate. So in a year and a half, you paid for it just by watching diabetes go away. Now in the duodenal switch, we tell people you can lose 45 to 50% of your weight. So that 400-pound patient can get down to 200 pounds. Now you've done something. And our best weight loss, our record is we had a patient that came in well over 600, lost 412 pounds.
Wow.
So, yeah, I mean, so I don't think there's any comparison. I do think the medicines have a role, and I think we need to know more about them. We need to know more long-term effects because those really have not been studied in non-diabetic patients. Before we go all, head in, hopefully not into the shallow end on this, but so you got to weigh those things out. And I just don't think those discussions are being had with patients when they start the medicines. And number one, this is forever. Number two, if you stop it, weight comes back. And it's like, I take a high blood pressure pill. I don't know if it's doing bariatric surgery or having 3 daughters and a wife, but for some reason I have high blood pressure. So if I take it for 12 months and then I stop it, do I expect my high blood pressure to be gone? No, it's gonna come back. So that's the mentality that you need to see in the discussions that should be had with when providers are talking to patients about the new medicines. It's meant to be for a treatment of a chronic disease, obesity, and forever. And that is not being had with the vast majority of patients.
I think there's another aspect to it. As a physical therapist, I talk to individuals that are obviously in need for a joint replacement, right? And their
Right.
wish is like, no, I'm just gonna let me just try and push it another year. And I'm saying, yeah, we can probably help you push it, but in a year time, you're going to be that much more, that much more pain, the quality of life, you're gonna have systemic issues, right? So
Correct. Yeah.
so the waiting is more costly than just the finance. And I think with
Yep.
bariatrics, it's the comorbidities might not be felt like a knee pain, right? Because of the diabetes and the pressure and the stress on the body is
Right.
not so clear.
Well, and if you have knee pain, your knees hurt, and your knees hurt, it's hard to do much of anything. And what the thing is, most knee surgeries can possibly be avoided by weight loss surgery. One pound equals 4 pounds of pressure on your knees. So if you lose 100 pounds, or let's say you're 100 pounds overweight, your knees are carrying the pressure of 400 pounds. And then you're just like, okay, well, let's go exercise. Like, are you crazy? Just go strap on a 100-pound vest and go walk around for a day. Your body will be so sore the next day. Exercise will be on the last thing on your mind. I tell tell people all the time, bariatric surgery patients are the strongest ones out there. To carry that kind of a weight and have that kind of pain. The thing about weight loss surgery is, especially when it comes to knees, and you know this because you see them and they need to get the weight off. But this idea of, well, I'll replace the knee. Now your knees won't hurt. Now you can start exercising. That's not going to happen. In fact, most studies will show that less than the reason why surgery is so effective is because any other method works less than 1% of the time for sustained weight loss over 2 years to get down to a normal BMI. It's just almost impossible. And so if you can lose the weight, say you still have knee pain after you lose the weight, you still need knee surgery. Well, you've just decreased your risks of having the knee replacement because you're 100 pounds lighter or 200 pounds lighter. You're going to be able to do the rehab a whole lot easier when you're at a normal weight. A whole lot easier. In fact, the physical therapists that I've worked with, they would much rather take somebody a normal weight than 200 pounds overweight.
Of course.
And then it's going to last longer. So it's my opinion that no one should ever have, if your BMI is over 35, you should almost always undergo weight loss surgery before knee surgery. Same for back surgery. I mean, some studies will say that half of all surgical back pain can go away with significant weight loss. And I've had back surgery. You're not the same after back surgery. I mean,
Yep.
you're just not. You can make a lot of the pain go away, but you're not the same. And once you start removing and cutting out bones and putting in steel, titanium or whatever it is these days, you're just different. You're just different. So, losing weight, there's not a downside.
Yeah.
At the end of the day, not a downside.
Now I know that your practice specifically appears to me to be very holistic in the approach of just it looks like you're doing so much more than just surgery for patients, right?
Yeah,
Within
so we have a bariatric medical specialist do all the work up on the front end. We've got 5 or 6 registered dietitians in our office, nurse practitioners, PAs that do all of the long-term follow-up, managing weight, vitamin levels, all the nutritional stuff. Because it is, ultimately what I tell every single one of my patients is that we're married after this, and follow-up is the key to maintaining the weight loss and preventing any kind of nutritional issues. You gotta take your supplements, and you gotta come back and get your labs checked. And so one of the pushbacks sometimes weight loss surgery is, I don't want to take vitamins. Like, well, every human should be taking vitamins at this point. And then I always say, look at somebody that you think is like really fit, like an athlete, somebody who works out, watches their diet, and then go ask them how many supplements they take a day. Everyone does it. You need to do it. It's better than taking diabetes medicines and high blood pressure medicines. I mean, it's a way better substitute.
what about the new procedures that are coming, right? So you like the DS. What about the Sadies of the world and those modified
Yes.
duodenal switch?
So the modified duodenal switch, that's my favorite one. The SADI, single anastomosis, duodenal ileostomy, and modified duodenal switch, SIPS, loop DS, they're all the same thing, all the same surgery. I just don't like the name SADI. I don't think it describes the whole surgery. So, in my mind, what all that was done is the old duodenal switch was modified. It was made better. It's still a duodenal switch. So, SADI, single anastomosis, duodenal ileostomy doesn't say duodenal switch, but that's what it is. And it's a great surgery, and it's what we do, and not much like Aetna and Cigna now cover that, not just the old one. So we're still working on the other pairs, but we do a lot of them, and it has been an absolute game changer in weight loss surgery because it's the best weight loss. It has the least chance of long-term weight regain, and there are no restrictions on any medicines the way there are with like the gastric bypass, where you can't take ibuprofen or steroids,
Yeah.
Motrin, Celebrex. And so some of those things, like, okay, maybe you're 30 years old and you're going to get arthritis in your hands in 25 years. You're going to want to take ibuprofen, or you become more active and you sprain your ankle, or you become more active and so your doctor's going to put you on ibuprofen or Celebrex, or you become more active with your family and you go camping and you happen to get into a whole mess of poison ivy. You're going to be begging for steroids. If you've ever had poison ivy, you want. So that was always the downside of the gastric bypass. And that's why when people like the sleeve is easier to do. It just basically, in my opinion, it's the next lap band. It's not that effective. Weight regain is too high. It's where the sleeve came from, the duodenal switch.
Yeah,
So it was
right. It was
half
a
of it.
phased procedure, right?
That's right. It was never intended in the beginning to be done by itself. But the weight loss isn't as good and the weight regain is high. So you got the duodenal switch it's the perfect combination of the modified DS of the weight loss of the bypass, but better, and the medication restriction profile of the sleeve, which is there are none. So it's just, I mean, been doing it for about 10 years. I've done thousands of them now. And I used to be pretty much 95% bypass. I am now 95% duodenal switch, and the patients love it. And they travel from all over the country to have it here. We've done patients from 49 of the 50 states, Canada, Scotland. They're coming from other countries now. I mean, seeking out this procedure because it works. It works so well.
So I'm curious, what does it, that's actually interesting to me. I, I'm a
Especially Arkansas.
well, yeah, no, no, that I actually can see why, but I'm curious. I'm an individual. I'm looking at surgeries. I recognize that's something that I want to do, but the thought of like traveling for surgery might be more daunting than the surgery, right? What is the experience for those patients?
Well, I mean, I think it's first of all, you get one really good crack at doing this right. Okay. So finding an experienced surgery, an experienced surgeon, an experienced program, and not somebody who puts it on their website and doesn't do it at all. And uh, that's a recipe for, an inexperienced surgeon with a not a quality program is a recipe for disaster. And bariatric surgery patients know that. They do their research. The average patient looks at doing this for 3 years. They know everything about me when they come in, but we've now have a lot of people on social media, patients that have done well and they're out there, and patients are like, that's me. I can do this. Who did that? I want the best possible chance at getting through this surgery safely and getting those kind of outcomes. I had a question the other day from a young surgeon, and it was like, well, how have you been successful? Well, you work hard. I go, you say yes when patients call, and you say yes when doctors ask. But the most important thing is outcomes. You have to have great outcomes. And you can't have great outcomes if you're always choosing the easy surgery to do on the easy patients and taking the easy way out. So the duodenal switch is a tougher procedure to do. It's a harder surgery, technically more challenging, takes longer, but the outcomes are so good that it's worth it. And I think patients appreciate that in a surgeon, that somebody is willing to take longer, do the harder surgery, take the time to train, to be effective, and decrease the complication, all that stuff. I think that, and so that's why they travel. And you know, Arkansas is right in the middle of the state. It's not like we're New York City or San Francisco or Dallas, but people love it. It's a great place. It's growing. This is where the corporate headquarters for Walmart, Tyson, JB Hunt Trucking. I mean, we have some large companies here that also now cover it. And so we do a lot of those patients from Walmart, Tyson, and JB Hunt, and it's been great. And these are recent developments. I mean, in the last 4 to 5 years, there's been coverage. So it's a game changer because the obesity problem is getting worse. It's not getting better. It's getting worse. Our interventions aren't working.
So if I'm traveling for surgery, do I come the day before?
Yeah. So what you do, first step in our program is you get on our website and you watch our online seminar. And it basically talks about our program, our practice, our surgeons, the procedures. If you want to sign up, become a patient, our team reaches out to you and you say, okay, I'm in, like I just did somebody this week from Montana. And you say, okay, our team will reach out. We'll do a lot of the preliminary workup that we need in Montana. Then we'll say, okay, here's going to be your surgery date. We'll see you on a Monday, do surgery on a Tuesday. You recover. We'll see you next Monday. Then you go home. So we basically tell people we need a week of your time. And it's been only. So if anybody from Vermont is hearing this, that's the only state I'm missing, by the way. So we've had them come
We
from
need
Alaska,
we need the
Hawaii.
Vermont card.
That would be 50 out of 50 sounds better than 49 out of 50. So, but I mean, we've got that process down really, really smooth to make it as easy as possible for the patient. I mean, that's the thing. We want this to be, hit the easy button. Not that surgery is easy. It's not the easy way out, but it shouldn't be daunting because, people feel very comfortable in our office, and that's my background. That's our office right there. I mean, I think we've got one of the best bariatric facilities in the country. We are now doing these surgeries as outpatients. So our surgery center got up and running in June. We're probably done I don't know, 70, 80 of these cases now, still working on their insurance contracts, but sending duty on switch patients home in 3 to 4 hours. And then they get to sleep in a nice bed or hotel bed, something comfortable. They actually get to sleep and not get woken up every 30 minutes, to get your vitals checked, or, hearing people talk out at the nurse's station, the lights are on, and your significant other, or family or friend, whoever's staying with you is not sleeping in that, recliner that, stretches out into a death trap that you have to sleep in for a night. And now you got two miserable people the next day because they didn't get to sleep. And so that's the advantages now, of being able to do this on an outpatient basis.
Sounds amazing. Um, okay, I'd like to shift gears a little bit, move away from bariatrics. I'm a healthcare provider, but I'm a techie by heart. And
Okay.
I always ask those I bring on the podcast is like, what is an app, a website, or a gadget that you're using in your regular life that you feel like made a difference for you recently, or just curiosity.
Let me see. I'm gonna check my phone and see what my apps are. I developed loss surgery selector a couple of years ago, and our patients use, and lots of patients, anybody can use it, but it's called the weight loss surgery selector. It's on the App Store, and what it does is ask patients to go through a series of 30 to 40 questions, about your history, your family history, your physical history, medical history, that kind of thing, to figure out what might be the best surgery for you based on what medicines you're on or not on. And then it'll spit out an answer, of something that could be the best for you. And then it gives you some links to information on our website to go look up that procedure so you learn about it. But it helps patients target what they need to research. Is the sleeve the best, the bias the best, the duodenal switch the best? So that is something that I guess I forgot I got involved in developing that app. And so our patients come in much more knowledgeable and to have those conversations with our surgeons and doctors, because we're able to, if you just get down and Google bariatric surgery, I mean, just like with anything else, you're going to get a lot of stuff. And sometimes it's hard to filter out the noise to get down to what you really want to know about. So that was the whole purpose of the app, was to get patients. And then, because what happens if you, let's say, duodenal switches, it says maybe your best procedure for you, but most doctors don't do duodenal switch. So you go in, if you're not armed with information to have that discussion with your surgeon, like, oh no, you shouldn't do a duodenal switch, it's way too dangerous, or some nonsense that they usually say, only because they don't do it. That then helps the patient go to the next, find the next person that they can do it. And so I think education and information is just really important when making these kind of decisions.
Summarize, how can a patient, what is your website? How do patients find you? Where should they go?
So it's rollerweightloss.com. We've been doing this for 17 years now. As a practice, we're well over 20,000 procedures. I'm over 11 myself. Probably one of the most experienced groups, or if not the most experienced group in the country. Once you go there, you watch that online seminar. It's about 40 minutes. You can watch it anytime, 2 in the morning if you want. Once you do that, our team will reach out to you, get all your questions answered. Check your insurance if you don't know, and figure out what needs to happen with insurance, and then we'll get the process started. And again, we want to make it super easy. You come in, you see our provider, you see the dietitian, we start educating you. We do what it takes for insurance, or we also have financing options that we do on our self-pay patients. And then we get to the OR and you start losing weight. You start feeling better and happy and healthy. And, we talk a lot about that, but one of the most important things too is, you mentioned it a little bit, is quality of life. This isn't just about getting rid of diabetes and living longer. It's living better. And that's what we do. So we're a phone call away, but that first step is watching that online seminar. Our Instagram page is Roller Weight Loss. Same with Facebook, but we have lots of just super inspiring stories on there. Real patients about their journeys and their before and afters. And that's the best thing about weight loss surgery. The before and afters will blow your mind, and you can't fake those. You can't Photoshop that kind of stuff. So you know it's real. We're an open book, but we love to take care of as many people as we can. Obesity is killing our country, and we gotta work hard to get it back. And I think bariatric surgery is a good first step.
That's a strong message. Thank you so much for taking the time to join me here today. It was really interesting.
Absolutely happy to do it anytime.
I'm Eran Kabakov with Connecting Health Professionals with People. To learn more about the podcast and sign up to be a guest, please visit pronexinc.com.